I'll tell you, this is the most framework heavy part of the week. We will ourselves be designing lots of frameworks, so they'll be constantly encouraging you to think about things conceptually. But I wanted to make sure at least when you see one of these diagrams, you're not floored by it. At least you know where it's coming from, okay? So this is not really a framework in my view. This is a kind of simple way of showing something that happened around 2010, which is the introduction of approaches from systems thinking. And here the idea is that we need to look at the health system as a system. And what exactly does that mean? It's the idea that if you think about a system, a bicycle is a system, a respiratory system is a system, right? It's all about having to have components that work together in order for the bicycle to move or for you to be able to breathe, right? So in the same way, the idea of the systems thinking in health systems was moving away from isolated blocks or functional inputs to this idea that everything is interconnected, and we cannot really look at one component without considering what's going to happen in other components. So that also helps determine the HPSR research questions. It is you're always thinking about things in terms of their impact on other aspects of the system. So you're examining how things are connected and how they connect in the sense of an entity, the whole system. The methods and the theories in systems thinking are designed to address complex problems, and we're going to talk about complexity more excuse me, as we get along in the course, because we'll come back to complexity in terms of understanding contextual factors that have bearing on health systems functions, but we'll also come back to complexity when we think about analysis. What makes something complex? A complex problem is where you have multiple interacting agents within a changing context. It means that it's impossible to look at how things happen in a linear way. It's non-linear and it's adaptive over time, okay? And we'll think about that. But basically, if you think about most health systems interventions, so for example, something that you introduce which is a provider incentive, or it's even a new technology, it is complex. What makes it complex? Because as soon as you introduce a new technology, it's not about that technology working by itself in isolation. You're going to have people who believe in the technology, who are going to use it, who know how to work it, and who use it, make the right decisions about when to use it. Yeah, so immediately there's complexity around the feasibility, the practical, the operational aspects, and so on. So most interventions, I would say, are complex, but there are simple interventions. For example, when you say, I'm going to change my drug regimen, that's relatively simple if it's very clear who's going to administer that drug regimen. So I'm changing my TB drugs, which used to be so and so many months, down to a shorter regimen because this is less toxic for the patient, et cetera, et cetera, et cetera. So that's a relatively simple intervention. But anything that is impacting on human behavior or the interaction of humans with technology or equipment or whatever is actually a complex intervention. So another feature is that most global health issues are recognized as complex problems and they need some kind of model or framework. So in your case, each of your groups is going to be working on an issue which is quite complex, and you're going to be thinking about a framework to conceptualize that problem. The other assumption is that systems behavior is governed by principles that can be observed and formulated. So we agree that systems can operate in unpredictable ways, but we think that with policy and systems research methods, we have ways to document what's happening and why it's happening. So systems thinking basically involves shifting your attention from individual parts to a whole, from objects, to relationships. So in terms of the object, again, the visual image you should have is a machine, a machine that's introduced to screen better, or a tablet that's introduced to do something. You're not interested in the object, the technical capacity of the machine. You're interested in what it does to the relationships between health workers and managers and researchers, etc., who would like to see this work in the best optimal way possible. From structures to processes, I would say we're interested in both structures and processes, but the interaction between. From hierarchies, like those, to networks. So the next step in your diagram would be to say, okay, so this is your traditional hierarchical structure of the health system. But in systems thinking, we're more interested in the dynamic interactions that cut across those levels, those hierarchical levels. Because some people are able to bypass the system and jump forward or backward, and others aren't. So what are those informal gatekeeping mechanisms? We're interested in moving from the rational to the intuitive. So by rational, in standard health systems performance analysis, there is an assumption that, there's a kind of economic thinking that dominates our understanding of performance. Whereas in systems thinking, we understand that human behavior we're not robots, right? We don't think like the economic man or woman always, but we have norms, we have values, we have subjective reasons why we do things the way we do. From analysis to synthesis, and from linear thinking to non-linear thinking. So now we go back to the macro, meso, and micro. I talked about this already this morning, but this is just to resume. In the reader, you will see that this is kind of your diagram for the different levels at the global, national, at the domestic, the local health system, and the micro level, which is concerned with individuals. And we again spoke about the fact that you can pitch studies at different levels, but you can also do a micro level study with policymakers because it depends on the focus of the study. So we won't go into that too much more. I just wanted to show you, again, this is a kind of organogram, organization of the Slovenian health system. And here, what I found interesting about this one, I'm always going to show you different diagrams because the way people conceptualize the health system is that this diagram looks kind of standard and a little bit boring initially, but actually it brings in people and it brings in some things around process. So it is telling you also something about, do you remember the control knobs framework? So it's introducing aspects of the control knobs framework into this diagram because it's telling you who has the power to regulate whom. Okay, so let's just spend a little more time on the macro, meso, micro. You can analyze health systems at these three levels, and at each of the three levels, you, for the most part, are concentrating on different actors, structures, and processes. So in the macro level, we're looking at national global policies, financing, governance, and the kind of key actors here are governments, organizations, regulatory bodies. So, what does the WHO, new policy on community health workers, what impact does it have on, India's changes to whatever, X, Y, Z. So that's a kind of typical macro level study, or a comparative policy study is a macro level study. The meso level is organizations and networks implementing policies, so hospitals, insurance schemes, district health authorities, and the micro level is really that interpersonal interaction, different kinds of health workers, right? Here's just some examples of questions, because I think it's always helpful to look at an example. How do national health insurance policies shape access to care for marginalized populations? It's a macro level question because you're looking at a broad policy and how it's and what it means for access. It's not telling you anything yet about the methods because you could use very different methods to address this question, right? The meso level, how do hospital management practices influence provider motivation and patient outcomes? So the hospital has some policy of rewarding, paying out a bonus to facilities that are performing better. How's that impacting overall on provider motivation? And then here, micro level, how do informal provider-patient interactions shape antibiotic use? So that's quite interesting, right? It's looking at the level of, say, drug shops, pharmacies, or providers. Does the relationship between the provider and the patient make a difference to how willing the provider is to hand over antibiotic prescriptions, even if it's not warranted? And we've seen that very often, that the way antibiotics are prescribed or handled often has to do with gatekeeping mechanisms. So again, implications for health policy and systems research is we're looking at the interconnections, we're highlighting the social and the political, we're looking at complexity, focusing on micro, meso, macro. And usually we're starting from a model of the health system to identify the problem. And we're going to spend tomorrow, after tomorrow's recap, we're going to spend time on how do you go about identifying a problem. So for many of you who want to do PhDs, you might actually be struggling with identifying a good problem that you want to start with. You know AMR is a problem, but what is your question? Yeah. So we're going to spend time on that. So what is the problem? How do I set priorities around the problem, and how do I formulate the aim? And yeah, we use a holistic approach. Okay, we're going to stop there. But we've already had our break, so no more break. But what I was going to give you as the last thing of the day, the next 5 minutes, is I want to give you an example of a systems project that we conducted in South Africa, because it really illustrates the interdisciplinary nature, the holistic nature of a problem, the micro, meso, macro level, and also getting at different kinds of questions and using mixed methods. So this is a project which is, first of all, okay, let me just quickly go back and just tell you that also what's interesting is that this idea of applying systems thinking is becoming definitely more popular in public health in high-income countries. So I'm just highlighting some recent documents. Health and Social Care in the UK, again, introduced this notion of a whole systems approach about identifying various components of the system, assessing the nature of links and relationships between each of them. So this is just, I'm going to give you a bunch of examples that show you that it's becoming common currency, which, as Solomon and Abhay know, it certainly wasn't 20 years ago, right? Another example is from Public Health Scotland, the country that I lived for more than 10 years. And here they're using a whole systems approach to apply systems thinking to better understand public health challenges and identify collective actions. And I believe they have focused in on one area, which is obesity, as one of the areas which is very, it can kind of be addressed through a whole systems approach. Another one, sorry, these are all UK examples, but I think they're really forward in terms of bringing these kind of approaches to public health. This is one on mental health, mental well-being. And then the last one is, this one is from the EU, a systemic whole school approach to mental health and well-being. So again, bringing in systems thinking, a systems approach to public health issues. So I'm going to give you an example from our own research. The background, this is the Umoja Umuhle study. Umoja Umuhle means a breath of air, and it's essentially looking at infection prevention control for nosocomial infection. So basically this is what happens when you have transmission of drug-resistant TB within clinics. That is as a result of the transmission patterns or risks within the clinic itself. So what we were looking at here, the problem was, we know that there's a high burden of tuberculosis and drug-resistant tuberculosis in South Africa, but what had been neglected is really understanding that health facilities themselves, there had been so much emphasis on community burden that nobody was really looking at what was happening in the health facilities. And these are really neglected sites of MTB transmission. And also recognizing the fact that health workers are at high risk of occupational acquisition. And that in fact, one of the things that was driving this issue is a major gap between policies and practice around infection prevention control in health facilities. Now, obviously this project was conceived before COVID, and you can imagine during COVID and after COVID, there was a lot more emphasis on airborne transmission, right? So things may have changed. I mean, mask wearing became much more common than before, thinking about ventilation and so on. But at the time when this project was conceived, which was about 5 years ago or 6 years ago now, there was really a recognition TB infection control is a problem, and often health workers were blamed, yeah? So it was usually health worker non-adherence. They weren't wearing the masks, they were sitting in rooms where they had the air conditioning on but no ventilation, etc. So a lot of blame placed on the health worker. So these are elements of TB IPC. They refer to a hierarchy of controls, which just means that there are different kinds of measures that are adopted to reduce the risk of transmission. They include administrative measures, environmental and respiratory protective measures. So by administrative, we mean, for example, how do you decongest a waiting room? Yeah, you introduce maybe a queuing system, an appointment system, but basically you want to reduce that congestion in a space where you might be bringing patients together, some of who may have, as of yet, undiagnosed TB, right? So administrative measures refer to changes in organization of services. Environmental have to do with introducing measures that have bearing on the actual quality of the air and the flow of the air. So what's called a whirlybird, which looks like that, but it's something in a health facility it is about your construction where your windows are, policies on keeping your doors open, etc. And respiratory protection is essentially your N92 masks. So these are intended to reduce risk for staff and patients by reducing the exposure and transmission, and they're usually made visible in standard practice, so masks, gloves, guidelines, and so on. Now, basically what we said is that the core components of IPC programs, according to the WHO, they talk about guidelines, education training, surveillance, and they talk about this idea of the enabling environment. So what is the environment that will, support adherence to IPC guidelines? This is a general IPC guideline one. And they talk about workload, staffing, bed occupancy, built environment, materials. So these are very structures. Yeah, they're about how many beds are occupied, how many staff are in place, what does the construction of the building look like. But what we said is that actually this enabling environment didn't take enough account. It focused mainly on the material components, but it didn't really take account of practice or behaviors or relationships. So the social infrastructure, the enabling social infrastructure, was less visible. So our aim of this big project, this was a £2 million project, which ran over 4 years, was to look at the social, the biological, and the infrastructural dynamics of nosocomial transmission of DRTB in 2 South African provinces with the aim of informing health systems interventions to improve IPC for TB. So what was our HPSR approach here? It was comparative. We were looking at different provinces. We were differentiating facilities in terms of their age, their size, their catchment area, because we thought that might have bearing on the TB load, but also on the facility running itself. Our research was contextual. We were trying to situate policies, processes, and practices at the clinic level within the structure and the functioning of the whole system. So what else was going on? Not just TB, but what were the policies around, for example, chronic care, where the medications, were being picked up, or what was the flow of services that might influence the level of congestion in the facility. Complexity, TB IPC was seen as a complex intervention with many interacting components. And the project was interdisciplinary, so triangulation of different methods, perspectives, sources of data on IPC. So these were our 6 work packages. The first one was an analysis of IPC policy, the history of IPC policy in South Africa. The second one was an epidemiological study. It was a prevalence study nested within this health system work. So this was looking at what is actually the burden, the prevalence of nosocomial transmission. The third was a study of clinic design and work practices, so very much looking very closely at what does the space look like, where are the windows, how do people move through this space. And the fourth was about healthcare worker and patient ideas and practices. So how did people feel about wearing masks or opening windows in a country where it's so hot that you actually don't want to open the windows. You want to keep them closed and put the AC on, even though it's not great for circulation, right? And all of that information led into 2 packages which were around designing an intervention. So one was coming up with systems intervention. So what did we need to change in the system? Infrastructural aspects, patient flow aspects, waiting times, all the different kinds of interventions that would possibly have an impact on nosocomial transmission. And we had a mathematical modeler who actually looked at how these interventions, how they would project onto the numbers. And then we also looked at how much these interventions would cost. So this is a very comprehensive project in terms of its questions. So again, just taking us back to the micro, meso, macro, here you can see those packages, those questions at the different levels. Micro level, day-to-day working practices within clinics, how people understood risks and so on. Meso level, we were looking at transmission patterns. Now you might say that doesn't sound very health systems, but it was situated at the meso level because we were looking at it at the clinic-wide, and we were looking at organization of care, and then at the macro level we were trying to understand how policymakers had progressed with this discussion. So one interesting thing in South Africa is the AMR people and the DRTB people are separate. They don't really talk to each other, which is crazy because DRTB makes up 25% of AMR, but it's a separate field. Okay, so I want to say that this was not without challenges, okay? And this is the message I want you to take away. Not the only message, we'll see what messages you have. But for the end of the day is to remind ourselves that health policy and systems research is very interesting, exciting, and challenging. But it's a big step, okay? Because you're forcing, it's like a forced marriage, right? We were really in a forced marriage in that project because, I mean, the amount of arguments I had with there was one person who was ultra focused on ventilation, that's all he did. He's a ventilation specialist. So CO2 measurements. There was another person who was only focused on waiting times, who wanted to click every time people went in and out. I said, but surely it's not just about clicking numbers. It's about why are they moving around? And they said, no, I'm not interested in that. I'm just interested in taking account of what is the patient flow. So all those specialists had to sit together. So the team itself had very different perspectives as to what is compromising IPC here. Yeah? What is being investigated? What is our focus here? What is going to make the biggest difference? And it led to very different understanding of what was a valid source of knowledge about the problem and how to collect the data. Also different logistics, different pace. Yeah? The qualitative researchers insisted that their ethnography of facilities would take 3 months. Everybody else was ready to throw them out of the team because they said, no, you can't afford 3 months, no way. And the ethnographer said, no, okay, fine, 2 months, nothing less. So you can imagine, yeah, big arguments. And also the research participant dynamic. So the more social scientists were very cautious about the ethics, clicking people in and out or whatever it was. And the quantitative researchers, I mean, this is slightly stereotyping, but they were less bothered with what they thought was, okay, maybe not such an ethical issue. So different discussions about what was permissible and not. Lots of challenges in bringing different types of papers together, a need for frequent discussions, reaffirmation of the value of different observations, and dissemination for different audiences. But I have to say, it's probably one of the most successful projects I've worked on. So if you look up this website, you'll see that there's, I think, 26 papers published from this project, spanning the full range of very narrow stuff on ventilation, and then, very rich ethnographic content, and then there are a couple of editorials which try to bring things together. So it's a nice example to end on for today. I hope you enjoyed the first day, and I'm sorry we were off a little bit with timing, and I apologize to our film crew for interrupting many times and being a bit hopeless with the slides movement. But I really was very, very impressed with your participation so far and your diagrams, so I'm looking forward to more. All right.